IC number 66 is Approach to Ocular Inflammations, and the Chief Instructor is Dr. Pappa P.
Very good afternoon to all. Welcome to this session on ocular inflammation. First of all, I would like to thank KSOS and the Scientific Committee Chairman, Dr. Rajini, for giving us this chance. In this session, we will be dealing with the most common ocular inflammation, that is uveitis. What are the newer investigative modalities, the treatment trends, the Indian scenario of the disease, how to do a good cataract surgery in a uveitic patient, and what are the expected complications of this disease. My co-instructors are Dr. Sudhavi. She is additional professor from Government Medical College, Thrissur, and Dr. Rekha. She is also from Government Medical College, Thrissur. We are very fortunate to have Dr. Kalpana Babu as our guest speaker. First, I invite Dr. Sudha to introduce the guest speaker. Thank you.
Thank you, Dr. Pappa. We are indeed honored to have with us Dr. Kalpana Babu Murthy, who will be delivering the keynote address on the uveitis spectrum in India. Madam is the head of Department of Uveitis and Ocular Inflammation at Prabha Eye Clinic and Research Center, Vittala International Institute of Ophthalmology, Bangalore. She has very high positions in many of the important societies, uveitis societies of India. She is presently Vice President of the Uveitis Society of India, Secretary Global Ocular Inflammation Workshop Society, Section Editor of the Uveitis and Indian Journal of Ophthalmology, and Treasurer of International Ocular Inflammation Society. She has multiple awards, including the Professor Narsingha Rao Award, AIOS Award, the Colonel Rangachari Award, etc. She has 96 peer-reviewed publications in different journals and has been an invited faculty in many national and international meetings. Over to you, Madam.
At the outset, I would like to thank Kerala Ophthalmic Society for inviting me to be a part of this annual meeting. In the next 20 minutes, we shall look at the spectrum of uveitis in India over the years. For the purpose of this talk, I have divided the spectrum of uveitis in India before 2010 and after 2010 and looked at the changing patterns and the possible causes of the changing trends. We will also look at the newer infectious etiologies which we are seeing in India, and finally conclude with a note on the current approach. In the late 90s and early 2000s, there were only a handful of uveitis experts in India, and uveitis care was restricted to tertiary referral centers. When we look at the literature of pattern of uveitis in India before 2010, we have had two studies from South India, one from North India, and one from Eastern India. What we do note is that anterior uveitis was the most common type of uveitis across all the four studies, and this was followed by posterior uveitis in majority of the studies. It was not possible to identify the etiology in more than 50% of cases of uveitis in the earlier studies, while the later studies showed that it was possible to identify the etiology in more than 50% of the uveitis cases. When we look at the most common cause of infectious uveitis, it was toxoplasma in two studies, tuberculosis in the study from Northern India, and leptospirosis in the other South Indian study. And when we look at non-infectious uveitis, VKH was the most common cause of non-infectious uveitis, along with HLA-B27 and Fuchs heterochromic iridocyclitis. This is a slide showing the different etiologies across the four studies. When we look at infectious uveitis in India, toxoplasma, tuberculosis, and herpetic diseases were more common. In addition, we also saw cases of leprosy-related uveitis, leptospirosis, cysticercosis, trematode granulomas, and CMV retinitis in the studies which were described during this period. Newer infections were also being described, and I will be addressing this a little later in my talk. Now, this slide shows the clinical patterns of different infectious etiologies. Coming to the non-infectious uveitis, VKH and HLA-B27 related uveitis were more common. Please note that serpiginous choroiditis was a part of non-infectious uveitis in earlier studies. This slide shows the clinical patterns of different non-infectious etiologies. Now, when we look at the literature after 2010, what we are seeing more number of studies and from different regions of India. We have 2 studies from Northern India, 1 study from Southern India, 1 study from Central India, another study from Eastern India, and 1 study from Western India. This means to say that we have more specialists treating uveitis in recent times. Again, when you look at the most common type of uveitis, anterior uveitis is definitely more common, and it is consistently the most common type of uveitis seen across all the studies. And this is followed by posterior uveitis in majority of the studies. Now, this pattern is similar to what we saw in the earlier studies. However, it is interesting to note that barring this study from All India Institute of Medical Sciences, it was possible to identify the etiology in more than 50% of uveitic cases in the other studies. Also, when we look at the most common cause of infectious uveitis, it was now tuberculosis, and this was consistently seen across all studies. When we look at non-infectious uveitis, HLA-B27 related uveitis was the most common etiology seen. Definitely, we can see a changing pattern. What we do see is there is a prevalence of ocular TB has increased significantly in recent times. There has also been an increasing trend of viral uveitis, and there is definitely a decline in toxoplasmosis and in CME retinitis. When you look at non-infectious uveitis, there is an increase in HLA-B27 related positivity, and we are seeing more number of cases of ocular sarcoid. So what are the factors which could be responsible for this changing pattern? One of the most important factors is to establish the etiology in more than 50% of cases of uveitis. And this is due to availability of newer diagnostic technologies like ocular imaging, polymerase chain reaction, and its wide usage in India. And this has been of great help in infectious uveitis, especially tuberculosis and viral uveitis. Thirdly, we are moving more and more towards high-resolution CT scans, and this is being preferred to chest X-rays. And we are also moving towards establishing a biopsy-proven diagnosis with newer technologies such as eBus-TBNA. At the same time, we are having increasing number of multicentric studies from India, especially in tuberculosis and sarcoidosis. And these studies have helped define clinical criteria in these diseases. Overall, there is a better understanding of the diseases in recent times. Let's look at tuberculosis, for instance. As I mentioned earlier, this pattern was what we used to call serpiginous choroiditis earlier. And these studies from India and the CORT study have established that this clinical phenotype is now called as serpiginous-like choroiditis. And this is associated with presumed ocular tuberculosis in high TB endemic countries like India. Similarly, Eales disease is associated with tubercular etiology in high TB endemic countries like India. In addition, we also have studies describing clinical predictors in tubercular uveitis. Let's look at a disease called sarcoidosis. Now, this disease is very similar to tuberculosis, and initially this disease was considered as a disease of the developed world. However, in recent times, we are seeing increase in the number of cases of sarcoid from high TB endemic countries like India, speculating the role of Mycobacterium tuberculosis in the pathogenesis of sarcoidosis. This is a slide showing the clinical patterns in ocular sarcoid. Please note the association of dry eye, which is quite commonly seen in patients with ocular sarcoid. And these are the posterior segment manifestations which we see in ocular sarcoid. Again, look at the candle wax dripping, which is very characteristic of ocular sarcoid. And we are also seeing this irregular depigmentation along with depigmented chorioretinal scars in ocular sarcoid. Recently, we published a multicentral study describing diagnostic markers which may be useful in differentiating ocular sarcoid from ocular tuberculosis in India. PCR has been very useful in identifying etiologies in viral uveitis, especially CMV-related anterior uveitis, and this is now being increasingly described from India. And this has made a big impact in our treatment management of these patients. Another important factor which is responsible for the changing pattern is the multidisciplinary approach. Over the years, we have learned a lot from our colleagues in other areas of medicine, especially rheumatology. And with availability of newer diagnostics such as EBUS-TBNA, we are starting to identify etiologies in many of our cases of uveitis. So we are starting to work together as a team, and this has made a great difference in management of our patients with uveitis. Let's look at pediatric uveitis, for instance. Now, this is a patient with juvenile idiopathic arthritis. In the earlier years, we would see very frequently such a pattern, and this was more of a sequelae of uveitis. Whereas in recent years, cases of JIA are referred to the ophthalmologist as soon as the diagnosis of JIA is made. And so seldom we see such ugly sequelae. We are also seeing increasing reports of blouse and early onset sarcoid from India. And this is thanks to our rheumatology colleagues and availability of genetic testing in India. I would like to mention here the importance of fluorescent angiography in pediatric intermediate uveitis. See, this eye appears quite, but actually when you do a fluorescent angiogram, there is extensive leakage, and hence ocular imaging helps in monitoring therapy in these cases. We have progressed considerably from steroids to biologics. Availability of newer drugs, our lower threshold for initiation of immune suppression, and targeted therapy with biologics have definitely resulted in better control of inflammation and hence a better prognosis. We have also started to use biosimilars, which have reduced the costs in treatment. And local steroid implants have also become standard of care in uveitis. On the flip side, thanks to these newer drugs, we are seeing an increase in the number of drug-induced uveitis, and it is important to be aware of the same. There has also been a huge impact of certain national disease control programs. And one program which is worth mentioning is the National AIDS Control Program. So if you look at the NACO report of 2015, there is definitely a decline in the number of new HIV infections in recent years. And there is an increase in the number of patients using antiretroviral therapy, which is now available free of cost. And probably this is one reason why we are seeing a declining trend in CMV retinitis in recent years. Coming to emergent uveitic entities, we are seeing resurgence of old diseases such as syphilis in recent times. In addition, we are also seeing newer entities such as retinitis, post-dengue, post-chikungunya, and post-West Nile virus infections. They now come under a group labeled as post-fever retinitis. And interestingly, they all follow a similar pattern of multifocal retinitis and in general, a good prognosis. unless if associated with vascular occlusions. So this is a patient post-dengue, and this patient had dengue maculopathy. Note the difference in vision over a week and with treatment with steroids. This is a patient with bilateral multifocal retinitis post-chikungunya fever and the dramatic resolution of retinitis over few months. This is a series from Dr. Ratnam's group, and these are patients with West Nile virus retinitis and neuroretinitis. And if you look, the clinical pattern is quite similar to what we saw in chikungunya retinitis. So generally, all these have a very favorable prognosis unless if it is associated with vascular occlusions. Though the CMV retinitis has decreased in HIV, there has been an increase in CMV retinitis in immunocompetent patients, especially after usage of intravitreal injections of steroids. Unlike the CMV retinitis which we see in HIV, these patients are refractory to treatment, requiring several injections of intravitreal ganciclovir. And these cases have a tendency to develop vasculopathy and ischemia, hence the need to follow up these patients closely for neovascularization. Now, Lyme's disease was never a part of differential diagnosis in India. Before 2010, there were occasional reports of Lyme's disease in India, but we published an article in 2010 describing Lyme's neuroretinitis. Since then, we've had multiple reports and case series from different regions in India. Now, when we look at the literature, we do see Ioxidus ticks in the Western Ghat area. So we did a seroprevalence in one of these regions, and what we noted was there was a high seroprevalence of Borrelia burgdorferi infection, and this was about 19.9% in these regions. And this was confirmed with Western blot, and this was positive in 15.6%. So it is very, very high, and which leads us to believe that any patient with clinical symptoms and signs of Lyme's disease and hailing from geographical locations as these, it is important to keep Lyme's retinitis as a differential diagnosis as well, even in our part of the world. Along with this, we are also seeing an increase in rickettsial retinitis in recent times, especially in children. So what has been the real change? I think it is the way we approach our patients with uveitis. Uveitis is no longer a niche area in ophthalmology. Because of a multidisciplinary approach, and there has been a rapid progress in technology, both in ophthalmology and diagnostics, as well as in other fields of medicine, especially with relation to therapeutics. And also there has been an efficient dissemination of information in the form of study groups, in the form of training at medical colleges and at tertiary medical centers, many CMEs on uveitis. We are very well updated with the latest trends in uveitis. So to conclude, the spectrum of uveitis in India is definitely changing. One of the reasons is global migration, and there is also an increased awareness among ophthalmologists for varying etiologies and presentations in uveitis. And this is both in infective as well as autoimmune uveitis. Also, we have improved diagnostics and therapeutics in India, and this has definitely resulted in better prognosis for our uveitis patients. Before I conclude, I would like to just share this photograph. This is one of our children with juvenile idiopathic arthritis 20 years ago, and you can see the band keratopathy, the corneal changes, occlusio pupillae, glaucoma. And this was what was 20 years ago when we didn't have good immune suppression. And this is what we are seeing now. relatively quiet eye in a patient with JIA with good doses of immune suppressive medications. This reflects the change in our care in treating our patients with uveitis. With this, I conclude my talk on an overview of spectrum of uveitis in India. Thank you very much for your patient listening.
Thank you very much, Madam, for that comprehensive talk and enlightening us on the magnitude of the disease in our country. Next, we will move on to the first speaker of this instruction course, Dr. Geeta Kumari. She will be speaking on Flag the Red Dye, that is about anterior uveitis. Over to you, Dr. Geeta.
Good afternoon, everyone. Anterior uveitis is one of the most common cause of red eye in our clinical practice. Most of the time, it is a clinical diagnosis. So, in this session, I am talking about the practical approach to anterior uveitis. Whenever you see a case of red eye, first of all, you have to identify whether it is anterior uveitis or not. Then we have to find out the extent of the disease, because it can be an isolated presentation or spillover uveitis from posterior segment involvement, or it could be a part of pan uveitis. Sometimes corneal or scleral inflammation can also lead on to anterior uveitis. So these are the challenges in making the final diagnosis. With a proper history, we have to stage the disease. With meticulous clinical examination, we can identify the severity of the disease and also type of the disease. In almost 50 to 60% of the time, it will be idiopathic in origin. But before concluding it as idiopathic, we have to exclude infectious causes, non-infectious causes, and masquerades. And finally, we have to exclude complications and also systemic association to avoid the chronicity and recurrence of the disease. Naming and measuring is an important clinical tool for uveitic workup. By naming, we are making a working diagnosis of the disease based on history and clinical examination. Then we have to measure the disease, that is, matching the clinical presentation with the clinical characteristics of the non-uveitic entities, so that we can find out the differential diagnosis. There are certain terms introduced by the Sun group, mainly based on anatomical location and certain specific clinical descriptors. So based on the onset, duration, course of the disease, we can classify the stage of the uveitis into acute, recurrent, and chronic. So in this picture, you can see it is a red dye with severe inflammation. So it is a case of acute uveitis. So what all things you have to ask in the history? Usually it will be very symptomatic with pain, redness, and photophobia with a sudden onset and limited duration of less than 3 months. The laterality is very important because bilateral presentation usually points to infections like TB, syphilis, etc. And also ask about systemic symptoms like low backache. If there is low backache with morning stiffness, it is suggestive of HLA-B27 associated spondyloarthropathies. In anterior segment findings, we have to find whether it is non-granulomatous or granulomatous. Usually, acute presentation will be non-granulomatous, and also look for any hypopion. And Iop measurement is very important. Most of the time in acute presentation, Iop will be low, but there are certain cases like viral etiology or toxoplasma is a part of pan uveitis or Posterior Segment syndrome. All these can lead on to increased IOP with acute presentation. And fundus evaluation is very important to find out any complications like papillitis or cystoid macular edema, and also to exclude intermediate and pan uveitis. These are certain systemic findings we have to specifically look for in case of acute uveitis, like kyphoscoliosis in ankylosing spondylitis, oral lesions in Bassett, etc. So now we can name the disease as acute anterior uveitis. It could be non-granulomatous or granulomatous. Granulomatous is usually rare, but you can see in viral uveitis or sometimes phacoantigenic uveitis. Non-granulomatous we can classify depending upon the frequency of occurrence, and most of the time acute presentation, almost 50% will be idiopathic in origin. And these are the common etiologies. TB, syphilis, and sarcoidosis can also present as non-granulomatous inflammation in its early stage. In this picture, eye is quiet, but you can see there is dense synechiae, there is complicated cataract and iris nodule. So it is a case of chronic uveitis. So in the history, it will be less symptomatic compared to the acute uveitis. Usually it is insidious in onset with a duration lasting more than 3 months. And also we have to ask about the systemic symptoms like chest symptoms or genital lesions, etc. And in the anterior segment, we have to type the disease. Is it granulomatous or non-granulomatous? Chronic anterior uveitis with non-granulomatous presentation usually seen in juvenile idiopathic arthritis and fugue septicemia hydrocyclitis. Certain features like iris atrophy, especially associated with corneal opacity, it is of viral origin, and sometimes 360-degree posterior synec can lead on to iris bombe formation with peripheral anterior synec, and it is the most common cause of IOP elevation in chronic anterior uveitis. So IOP checking is very important in all cases of chronic uveitis, and also gonioscopy to rule out any peripheral anterior synec, numerous in the angle, any nodule in the angle, especially in case of sarcoid uveitis, and also to exclude occult foreign bodies. Fundus evaluation is very important to rule out any intermediate or posterior uveitis. And certain systemic findings like cervical lymph nodes is specifically in TB, and poliosis or vitelliform leakage or herpes zoster scar, all these are indicative of certain granulomatous uveitis. Now we can mesh the chronic anterior uveitis into non-granulomatous and granulomatous depending upon the etiology. So what are the indication for investigation? Not all uveitis need investigation. If it is a first episode of unilateral mild non-granulomatous uveitis, there is no need of investigation because most of the time it will be self-resolving. If it is bilateral, recurrent or persistent non-granulomatous, we need workup apart from basic lab workup including TCDC, ESR. If you are suspecting Ankylosing Spondylitis, you have to do a sacroiliac joint X-ray, and especially if it is bilateral, you have to rule out TB, syphilis, sarcoidosis. All granulomatous anterior uveitis need investigation. You have to rule out TB, sarcoid, and syphilis. And if you are suspecting juvenile idiopathic arthritis, especially chronic anterior uveitis in under 16 age group with arthritis, you have to do ANA. And not all cases of uveitis need this workup, but if there is severe drop in vision, if it is a recalcitrant uveitis and the media is very hazy, we need posterior segment investigations like OCT and B-scan. And invasive diagnostic testing like aqueous paracentesis is helpful in some infections like viral, toxo, and some tumors, etc. So what are the treatment goals? We have to treat the inflammation and cause, and also to prevent the recurrence and complications. So the inflammation can start with topical steroid. We have to start at maximum dose and taper slowly. The slow tapering is very important in order to avoid the flaring up of the disease. So the tapering is mainly based on the activity of the disease, that is anterior chamber inflammation. If it is an acute severe anterior uveitis, we have to start the topical steroid in an hourly manner with a weekly follow-up. We have to maintain the hourly dose for at least 1 week. Then at 1 week, if there is improved activity means there should be a 2-step decrease in the inflammation. If there is 2-step decrease in the anterior chamber inflammation, we can taper the dose to 2-hourly dose and maintain 2-hourly dose for 2 weeks, then gradual tapering over a period of 4 to 6 weeks. At any point of time, if there is worsening of activity or flaring up of the disease, we have to step up the dose and it needs a very slow tapering. If it is a chronic anterior uveitis, there will be more flare compared to the cells. Then we can start the dosage with 6 times and taper according to the clinical response. So our aim is anterior chamber activity of 0. So whenever the cells become 0, we can stop the treatment with topical steroid. The next drug is topical cycloplegic. If there is dense posterior or hypopion, we have to start the patient on atropine, 1% eye ointment TDS. Once the pupil is well dilated and synec is broken, we can switch over to shorter acting homatropine. So the shorter acting homatropine, the advantage is it will keep the pupil mobile so that it will prevent the synec formation. And then according to the clinical response, we have to taper the cycloplegics. Once the cells become 0, we can stop the drug. Whenever the patient is non-compliant, or if you are suspecting cystoid macular edema, we can give periocular steroid. Periocular steroids, we can give either subconjunctival steroid or anterior subtenon or posterior subtenon. Posterior subtenon is useful in CMA. And systemic steroids are indicated especially in chronic uveitis, chronic anterior uveitis, especially if there is no response to maximum topical therapy, or if it is bilateral presentation or severe uveitis, and also if there is any systemic association. If any contraindication or side effects of steroids, we may also need immunosuppressants and even biologics. Then we have to treat the cause depending upon whether it is infective or non-infective etiology. Then treat the complications like secondary glaucoma, and complicated cataract. And complicated cataract, we can do the surgery only if the uveitis is quite, if the eye is quite for at least 3 months. These are certain examples for recalcitrant uveitis. In these cases, in order to prevent the recurrence, we may have to use immunomodulatory therapy, and if it is resistant to immunosuppressants, we have to use biologics, especially anti-TNF alpha inhibitors. So most of the time, anterior uveitis is a clinical diagnosis. So with a proper naming and measurement, we can tailor our lab investigation and can find out the clinical diagnosis. And not all cases of anterior uveitis need investigation, that we have to tailor our investigation. Thank you.
Thank you, Dr. Gita, for that very nice talk. Now, next to speak is Dr. Natasha. Dr. Natasha is a professor and senior retina consultant at Amrita Institute of Medical Science. She is an excellent speaker and a great debater, and she has many publications in national and international journals. Madam will be speaking on inducing remission in intermediate uveitis. So over to you, Madam.
I would like to thank KSOS and Dr. Pappa for giving me this opportunity. Snowballs and snowbanks inducing remission in intermediate uveitis is the topic we are going to talk about today. The diagnosis is made when ocular inflammation primarily involves the vitreous and peripheral retina. Intermediate uveitis was first described as chronic cyclitis by Fuchs in 1908. Pars planitis is used to describe a subset of patients with intermediate uveitis when a white opacity or a snow bank occurs over the pars plana and ora serrata. About 1.4 to 31% of all uveitis patients with an incidence of 1.4 to 2 per 1 lakh. Europe, United States, and China, mostly it is idiopathic. In India, infectious causes, especially TB, there is no gender predominance. In children, intermediate uveitis can occur up to about 29% of pediatric age group. The mean age of uveitis is around 8 to 10 years with a male preponderance. Snow banking is seen in 28% of patients. The etiology can be infectious, non-infectious, or idiopathic. More than 70% is idiopathic, but infectious causes include TB, leprosy, Lyme disease, syphilis, toxocara, and non-infectious sarcoid, Blau syndrome, multiple sclerosis, lymphomas, Sjogren's syndromes. There is an HLA predominance of HLA-DR in about 70% of patients. Symptoms and signs, defective vision and floaters in the absence of pain, redness, and photophobia should alert the ophthalmologist. Visual losses due to aggregation of floaters in the vitreous and due to macular edema. AC may be quiet or it will have mild KPs. And presence of vitreous cells that outnumber the AC cells and presence of vitreous snowballs and the presence of pars plana exudation suggest intermediate uveitis. Retinal changes that are acceptable without saying that it is posterior uveitis is tortuosity in arterioles and venules and peripheral sheathing. Neovascularization and exudative RD in the late stages is also possible. This is a characteristic vitritis in intermediate uveitis. It is a vitreous haze that can range from trace to 4+. Cystoid macular edema, snow bank, and snowballs are also characteristics. This is the actual snowballs that you can see in the periphery, and the snow banking you can see in the inferior exudation. Cystoid macular edema seen as a flower petal pattern. Ocular investigations that will help you are fluorescent angiogram that will give you the presence of vasculitis, areas of retinal non-perfusion, and OCT will quantify and qualify the cystoid macular edema. UBM can help in characterizing the pars plana exudates and to rule out retinal detachment and whether it is a mimicker or a masquerade like intraocular tumors. Diagnostic vitrectomy is done when you are suspecting something like a lymphoma or where there is severe vitreous inflammation where endophthalmitis cannot be excluded. Complications of intermediate uveitis include cataract in 15 to 50%, macular edema, epiretinal membranes, retinal vasculitis, exudative RD, and optic nerve involvement in the form of disc edema. And optic neuritis with or without multiple sclerosis can be seen in 7% of eyes with pars planitis. So how do we treat intermediate uveitis? The first step is to exclude the possibility of an underlying infectious disease or malignancy. And the second step is to decide whether to treat or not. Extensive neovascularization of the peripheral snowbank with substantial vasculitis should be treated even if the vision is good. Aggressively treat patients who develop macular edema or other complications of the inflammatory disease. A proper history is important: fever, fatigue, night sweats, loss of sensitivity of paresthesias to rule out possible MS, other signs of dermatitis in conditions like Lyme disease, arthritis in Lyme disease, and contact with cats in Bartonella. CBC, chest X-ray, ESR, PPD for TB, and chest X-ray studies may also give you sarcoid. And a combination of AC level and a whole body gallium scan increases diagnostic specificity without affecting sensitivity. So what do we treat with? First step, periocular steroid, deposteroid, that may be repeated every 4 weeks for 3 to 4 injections, and that is usually Kenacort or triamcinolone acetonide. If local therapy is not effective, or if you have bilateral severe disease, then you can think of oral corticosteroids. Step 3, systemic immunomodulatory therapy in case of, again, bilateral, or if corticosteroids fail or not tolerated or contraindicated. Step 4, if all these fail, then you have to think of peripheral ablation with cryotherapy and indirect laser photocoagulation. You can also add peripheral ablation of laser if there is evidence of vasculitis with non-perfusion in the periphery, which is likely to lead to neovascularization, or if there is evidence of neovascularization in the periphery. Pars plana vitrectomy with induction of PVD and peripheral laser photocoagulation can be done along with immunomodulatory therapy if the vitreous haze is very significant and you're not able to clear it with systemic immunosuppression alone. So posterior subtenon injection, like I said, is the most common local method that you will use. You can also use intravitreal injection of dexamethasone implant for those who do not respond to posterior subtenon, and the complications will be raised IOP, cataract, aponeurotic ptosis, and allergic reactions with conjunctival breakdown. However, generally PST injections are very well tolerated and give you very good result. Repeated PST injections may cause enophthalmos and orbital scarring. Immunomodulatory therapy is usually done with methotrexate, azathioprine, or MMF. Cryotherapy and laser photocoagulation, cryo if it is very anterior. Photocoagulation burns can also be placed just posterior to the snowbank, and treat the neovascularization associated with pars plana exudation with cryo or laser photocoagulation. This is how the cryo burns are applied in the periphery. To conclude, intermediate uveitis requires a systematic approach in diagnosis and treatment. The management requires a stepwise approach to prevent visual morbidity due to the complications, and the sequelae also require appropriate and timely intervention. Thank you all for your patient hearing.
Thank you very much, Dr. Natasha, my good friend, for that excellent talk on intermediate uveitis. And she is the one who started the uveitic group in KSOS. Next speaker is Dr. Sudhavi. She will be speaking on systemic management of the immune response. Over to you, Dr. Sudha.
Thank you, Dr. Pappa and Dr. Rekha, for giving me this opportunity to talk on systemic management of uveitis. The ocular immune privilege word was coined by Peter Medawar to describe the absence of an immune response to allografts placed in the anterior chamber of the eye. This is because the ocular microenvironment has immunosuppressive mechanisms. When an antigen is presented to the anterior chamber, it results in a predominantly T suppressor cell response, unlike in other places in the body where T helper cells are produced. And this is called the immune deviation of the anterior chamber. And the reason for this is that it is designed to preserve our foveal vision while protecting the eye. And when insufficient, the eye becomes susceptible to uveitis. So uveitis is a loss of this privilege. T cells are generated not against the antigens only, but also against the ocular antigens, that is the uveal melanin and the retinal S antigen and the interphotoreceptor retinoid binding protein. And visual prognosis is poor in severe inflammation because of damage to the retinal and uveal tissue. Systemic immunosuppressions can be done with 3 types of drugs: the steroid-sparing immunosuppressive therapy, and the biologics. Systemic therapy, before you start, you need to take certain precautions. You need to differentiate between infectious cases and non-infectious uveitis. Understand the natural history, because like diseases like APMPP is self-limiting, and you should avoid unnecessary treatment, expensive treatment, and inappropriate treatment. And always look at the risk-benefit analysis, whether the benefits of therapy will outweigh the complications. Treatment strategy is complete suppression of the inflammation. It should be grade 0 inflammation. The reason for this is any active uveitis, whether it is minimally active or strongly active, causes the same amount of damage. Monitor for various locations differently. For anterior and intermediate uveitis, it is based upon the reaction in the anterior chamber or the haze of the vitreous. But for chorioretinal disease, you would require a multimodal imaging, especially the fundus autofluorescence, which correlates well with the active disease. Systemic corticosteroids are indicated in bilateral uveitis, in severe unilateral uveitis or anterior or intermediate, which are unresponsive to periocular injections, in non-infectious posterior uveitis, and the pan-uveitis cases. Always start with the appropriate dose. You do not step up with a low dose. You start with usually 1 milligram per kg oral prednisolone, up to a maximum of 60 milligrams per day, because beyond that, it can cause ischemic necrosis of the bone. Continue until a satisfactory anti-inflammatory response is obtained. Usually it takes about 1 month. Along with this, give calcium and vitamin D. And if you feel it is acute site threatening, you can start with pulse IV methylprednisolone for 3 days and then start with oral corticosteroids. The tapering schedules will depend upon the inflammation subsiding. So usually it starts subsiding, gets stabilized by 1 month and starts subsiding by 3 months, and you will taper depending upon the dose you have used or it is being maintained at. So if it is maintained at 60 to 30 milligrams, you will taper as 10 milligram per day at weekly intervals. And if it is a 30 to 15 milligram, you will taper by 5 milligram per day at weekly intervals, and lesser doses will have lesser decreases per day weekly. So adjust the doses, that is, you have to adjust based upon the side effects, which could be raised blood sugars, mood changes, arrhythmias with IV methylprednisolone, and osteoporosis. So if side effects are seen at around 10 to 20 milligram per day, you can try alternate day regimen by doubling the dose. But again, by this alternate day regimen, if the symptoms are worsening, then you have to convert back to the daily dosage. If you want to start immunosuppressive agents because the inflammation is not subsiding, you have to be very careful. You should have an informed consent, a systemic evaluations for cardiac diseases, malignancies, demyelinating disease, rule out pregnancy. Comprehensive tests should be done before and at regular intervals, that is the complete blood count, LFT, RFTs, blood sugars, screen for TB, HIV, and hepatitis. And if you're starting on biologics, the patient should be vaccinated on pneumococcal influenza and the hepatitis B virus. And always inform them to consult a physician immediately if there is any sign of fever, sore throat, or bleeding. When do you give it? Now, in intermediate uveitis, it is given as the 3rd step, the Kaplan's 4-step treatment we have talked about before, and it should be given along with regional corticosteroids injections, oral corticosteroids, or immunosuppressants, and then only add immunosuppressants. In posterior and panuveitis, you start along with the oral corticosteroids. In other cases, like severe site-threatening cases, which are unresponsive to steroids even after 1 month of therapy, intolerable side effects like glaucoma in corticosteroids, if it recurs after decreasing the corticosteroids or even after stopping the corticosteroids, and if you want to permanently withdraw corticosteroids. Other indications is worsening of the symptoms with local therapy. For example, anatomic sequelae, if you get progressive synechiae and iris bombae, steroid-induced IOP, raised IOP, and cataract, uveitic macular edema, inflammatory scarring like CNVM, retinal capillary dropout, sunset glow fundus in BKH, and the visual field loss. Primary suppressive immunosuppressives are indicated in certain diseases, and these are as recommended by the International Uveitis Study Group, like Behçet's disease, sympathetic ophthalmia, BKH, JIA-associated uveitis, non-TB serpiginous carotiditis, and chronic intermediate uveitis, especially in children, because in children you cannot give a long-term steroids. How does primary immunosuppression help? In certain diseases like Behçet's disease, they reduce the risk of visual impairment and blindness by many folds. In birdshot chorioretinitis, they sometimes reverse the visual field loss and the retinal damage can be normalized. And all these diseases, the chance of recurrence is always reduced. So traditional immunomodulating drugs are of three types: the T-cell inhibitors, the cyclosporins, antimetabolites like azathioprine, mycophenolate mofetil, methotrexate, alkylating agents like cyclophosphamide. Which drug should we choose? Based upon side effects, you should not use cytotoxic drugs in children. In pregnancy and lactation also, they are contraindicated along with methotrexate. Do not use cyclosporin in people aged over 55, according to the site cohort. If a single drug is enough, then start out with mycophenolate mofetil, which is usually well tolerated for a very long time with minimum side effects. In children, you can start with methotrexate. If you feel there is some response but you need another agent, you can start T-cell inhibitors like cyclosporin along with these drugs. But if there is no response, then you have to switch on to alkylating agents like the cyclophosphamide and chlorambucil, and they can potentially cause serious side effects, especially cancer, so careful monitoring is required. After you've started, you need to continue for a long term, but you should also know when to start tapering. So remission inductions, they are a little uncommon with non-alkylating agents. You need to give them for at least 2 years after stopping steroids, and you have to maintain the disease as inactive during this period. Only after that you can try and taper and discontinue. But even in such cases, after a remission has been achieved, you need to monitor very carefully because relapses are common. Alkylating agents are remission inducing, and the total duration of these drugs should be less than 18 to 24 months. And the aim here is to have 1 year of inactive disease of the oral corticosteroids. So monitored by the WBC cells, they should be no lesser than 3000 cells per millimeters. The serum creatinine should not rise beyond 20 to 30% of the baseline value, and LFT should not rise by more than 5 times. And as the inflammation subsides, you taper it. Generally, relatively, they are well tolerated according to the MUST treatment trial and the follow-up study, especially along with maintenance prednisolone doses, which are less than 7.5 milligrams per day. The newer drugs are the biologics. They are targeted therapies for each step of the immune response, and they decrease the inflammation and the tissue damage. But they are not given as a first-line therapy. They are used when the conventional immunosuppressor therapy fails or it is not well tolerated. And so they're also given in certain systemic inflammations and certain types of ophthalmic inflammations. And the drugs are infliximab, adalimumab, tocilizumab, interferon, and rituximab. In systemic diseases like Crohn's disease, ulcerative colitis, psoriatic arthritis, rheumatoid arthritis, Wegener's granulomatosis, these are very useful drugs. And for ocular cases like recalcitrant uveitis, sarcoidosis, BKH, and birdshots. So this is our algorithm. When a patient presents with uveitis, first find out what is the anatomical location. Anterior uveitis and intermediate uveitis generally is treated with local therapy and periocular injections. But if it is worsening or it has a systemic disease, then you may like to add oral corticosteroids. If there is site-threatening inflammation, you can start with IV methylprednisolone and then switch on to oral corticosteroids. And if the inflammation doesn't subside after 1 month of therapy, then you can add a disease-modifying agent. But once you add them, they need to be treated for at least 2 to 2 years of inactivity. Thank you very much.
Thank you, Sudha Madam, for the excellent presentation. It was very informative. Our next presenter will be Dr. Rajini Casey. She will be speaking on challenges and concerns in cataract surgery in uveitis. Dr. Rajini Casey is the head of the department of Manjeri Medical College, and she was a former HOD of Government Medical College Thrissur. Rajini Madam is an excellent surgeon with vast experience in managing complicated cataract surgeries. So over to you, Madam.
Good afternoon, everyone. At the outset, let me thank the KSOS Scientific Committee Chairman, Dr. Rajiv Sukumaran, and Dr. Pappa, the Chief Instructor of this course, for giving me this opportunity. And I'm happy to be with the Thrissur Medical College team. Cataract surgery in uveitic eyes is challenging, and it presents with many unforeseen intraoperative complications. With improved understanding of the disease and the improved surgical techniques, the outcome also is better now. You need to have a systematic approach. And main indications for surgery are phacotoxic uveitis, or it impairs the fundus assessment in a patient with suspected posterior segment pathology, or if you are planning for a pars plana vitrectomy. A multidisciplinary approach is needed for management of JIA, Behçet's, syphilis, toxoplasmosis, and tuberculosis. And the first question that comes to your mind or to the mind of a patient is whether I am going to get back the vision after cataract surgery. So you need to assess the patient in such a way that the slit lamp examination may show a band-shaped keratopathy, the specular microscopy for endothelial cell count, the cornea may be decompensating already. Do a thorough fundus examination, and OCT will help you to assess the cystoid macular edema and a macular hole. And if the cataract is dense, you may have to use a B-scan. An assessment which patient is going in for a complication, especially hypertonia. The patients with poor control of inflammation are prone for developing hypertonia. And poor prognostic signs are low intraocular pressure, less than 6 millimeters of mercury, even when the eye is quiet, and the seclusion we play with a normal intraocular pressure, and apparent phacotonesis, and a diffusely thickened choroid. And use of UBM will help you to assess the ciliary body for a ciliary cyclotic membrane, which causes traction of the ciliary process with the resultant ciliary body detachment. And trimming of this membrane with silicone oil injection will be required to restore the intraocular pressure. And good gonioscopy will assess the cause for secondary glaucoma, and chronic uveitis like this will cause usually associated with secondary glaucoma. And counseling is extremely important, especially in these days, regarding the visual prognosis, prolonged surgical duration, and delayed visual recovery. And the patients have to be compliant for frequent follow-up, and you have to discuss with the patient regarding the IOL implantation, its design, its cost, etc., etc. And steroid usage, if the surgery is required urgently, you have to give the patient methylprednisolone 1 gram 2 days prior to the surgery. If the patient has no inflammatory activity, you can continue with their existing dose. And if the patient is on chronic steroids, you should go for a stress dose. And the use of laser flare meter is extremely useful in monitoring disease activity. And the patients who need a topical steroid other than maintenance dose, or a persistent posterior segment activity, or the patients who need a corticosteroid pulse to control inflammation like an Osidex, they are not adequately controlled. Intraoperative steroid usage will reduce the usage of the requirement of postoperative systemic steroids. And the main intraoperative problems or difficulties are due to band-shaped keratopathy, posterior synechiae, peripheral anterior synechiae, and a stiff pupil. And at times it is difficult to position a patient, especially when the patient is having a very severe kyphosis like this. We operated this patient, and you have to keep the OT ready with good equipments, with vitrector and the phacoemulsifier and the pupil expanding devices and instruments. And you have to be familiar with procedures like membranectomy, synechiolisis, and multiple sphincterotomies. And you can choose usage of drugs like intracameral adrenaline or intracameral lignocaine, mitraine, or omitria, which are newer drugs which you can use intracamerally. Or without the device, you can use retentive OVD, or you can use do procedures like removal of pupillary membrane, stretching of the Coughlin hooks, and avoid stretching if the iris is atrophic. And non-stretchable iris, you can put multiple sphincterotomies. And always remember, release peripheral anti-synechiae before tackling the posterior synechiae. And this is a patient whom we did a stretching, and the stretching is done in the two opposite quadrants. So we are getting a adequate sized pupil here. And your introduction of hooks, removal of introduction of hooks needs to at least 4 paracentesis wounds, and after implanting the intraocular lens, and a removal can be done. And this, after this removal, you have to hydrate these wounds, all the wounds. And these are 2 expanding devices, a deep anterior chamber with a stiff pupil. You can use a Malugin ring or a BHEX ring. A Malugin ring is a proline device which is available in 2 sizes, and 6.25 is a perfect one, and it's little expensive also, and BHEX is very convenient to use, and it is cheaper also. And let us see how it is being done. You have a lodger or a injector, and you can hook each area of the iris like this. And always remember to put at least 5.5 millimeter rhexis for cases which are operated for uveitis. And routine cataract surgery is performed in this patient in the usual way, and removal of the hook is done with the same lodger. So this is a patient who had a very bad cornea, diseased cornea, and she had a JIA, and intraocular lens was not implanted in the primary surgery. We are making a pupil more wider with the sphincterotomy and the membranectomy, and we could see a very thick membrane behind. And you can use a cervitractor also. In this case, I have used a sharp blade and a Vanna scissors to cut the membrane. And this is a patient whom we operated in the traumatic cataract, where peripheral anti-synechiae was released. I have released the other synechiae also. You can see the anterior capsule, which is already open. There is iris atrophy, so I have put multiple sphincterotomies so that you get a adequate sized pupil. IOL implantation is not contraindicated if the control of inflammation is optimum, and always aim for in the back placement of the intraocular lens, posterior rhexis, if the child is younger than 8 years, and avoid AC IOL, sulcus fixation, protein haptics, multifocal IOLs, and if the child is less than 2 years of age. And preferred lenses, hydrophobic acrylic lenses. And post-operative management, the crucial drug is steroids, and topical and oral steroids are the mainstay of treatment in the post-operative management. If you have already started on oral antivirals, you can continue. And complications, commonest is flare-up of inflammation. So always rule out an infective cause. An aggressive management with steroids and systemic and intravitreal is required. And pupillary membrane are commonly seen in JIA and VKH. And you may need a vitrectomy for a removal of vitrectomy membranes. And cystoid edema is another mainstay of treatment is again steroids, NSAIDs, and oral acetazolamide. Epiretinal membrane can be treated with ILM peeling, and posterior capsular opacification is more common in these type of cataracts, and absolute control of inflammation prior to capsulotomy is required, and there is a high risk of cystoid macular edema after capsulotomy. And transient rise of intraocular pressure can be managed with drugs. Secondary angle closure glaucoma may require a trabeculectomy, and hypotonia, as we have already discussed, can be treated with intensive topical and systemic steroids and a silicone injection in desperate cases. Visual prognosis depends on the presence of pre and post surgical inflammation, and the quality and efficiency of the surgical procedure and the treatment of complications. To conclude, pre and post-operative control of inflammation is crucial in achieving the good visual outcome in the management of uveitic cataract, and these patients need a very long follow-up, and timely detection and management of complications is important in maintaining the post-operative visual recovery. These are my references. And thank you for your patient listening. I once again thank the KSOS Scientific Committee Chairman, Dr. Rajiv Sukumaran, and the Chief Instructor of this course, Dr. Pappa, for giving me this opportunity. Thank you all.
Thank you, Rajini Madam, for that excellent talk on cataract surgeries in uveitis. Now, the next speaker will be Dr. Rekha, Assistant Professor in Ophthalmology at Thrissur Government Medical College, and she will be speaking on imaging in uveitis. Over to you, Dr. Rekha.
So good afternoon, everybody. I'll be dealing with imaging in uveitis, the image and the message. So first we'll see what are the indications for imaging. One is to come to a specific diagnosis, then to confirm a clinical diagnosis, to identify complications, to explain the cause for poor vision, and also to rule out Masquerade syndrome. We have a set of investigations, but OCT has gained so much of importance. It is because of the non-invasive nature. So first we'll deal with OCT in uveitis. The indications are to identify complications like macular edema, epiretinal membrane, CNVM, to confirm certain specific types of uveitis like weak age, and also to monitor the response to treatment. As you all know, macular edema is the leading cause of vision loss in uveitis. It is especially important in conditions like pars planitis, intermediate uveitis, Behçet's disease. So macular edema can be a diffuse macular edema where we get a spongy appearance, and if it persists, it can turn out to a cystoid macular edema where you get cystic spaces. That indicates chronicity. And here we have to look for the integrity of the ellipsoid zone. If there is a loss of integrity of the ellipsoid zone, that means there is a chance of poor vision. Now, subretinal fluid also can be seen, but it is not related to the site of uveitis. So what are the advantages? Here we can detect macular edema very early, so there is a chance of improvement in vision. Also, we can have a quantitative assessment of the edema, and also we can monitor the treatment. Epiretinal membrane is seen as a hyperreflective signal at the inner retinal surface with evidence of contractility. There will be corrugations in the inner retinal surface. It is mainly seen in intermediate uveitis. There is high incidence in intermediate uveitis. CNVM also can be detected very early, and we can give treatment and have a better visual prognosis. In weak age, the subretinal space is separated into several compartments by subretinal septa. That is one feature specific to weak age. Also, it is important in following up the patient, because we can monitor the response to treatment. We can take serial OCTs. Also, sometimes we may pick up CSR because of the intake of steroids. Now coming to OCT, enhanced depth imaging. This is to visualize the choroid. In normal OCT, the choroid is not seen properly. In EDI, the choroid is properly seen. And the thickness of the choroid is increased in certain conditions like weak age, Behçet's disease. So here, monitoring also can be done. You can see for the decrease in the thickness of the choroid. There are certain newer biomarkers like hyperreflective retinal spots. These are actually aggregates of microglial cells which are activated during inflammation. These also can decrease with the treatment. So that is the importance of HRS. Now, drill is a disorganization of the retinal inner layers. There is a difficulty to identify the limits between the ganglion cell inner plexiform layer complex, inner nuclear layer, and the outer plexiform layer. So a drill of more than 500 microns in the central 1000 microns is associated with poor visual acuity. So drill and ellipsoid zone disruption is associated with a poor vision. Now, ASOCT or anterior segment OCT is important if there is a corneal opacity and we are not able to do a proper slit lamp examination. So here we can see the keratic precipitates as hyperreflective spots attached to the cornea, and inflammatory cells in the anterior chamber can be seen as hyperreflective spots in the anterior chamber. Now, next one upcoming investigative modality is OCTAR, OCT angiogram. Here, capillary in uveitis, the capillary non-perfusion areas can be seen, especially in retinal vasculitis. Also, we can detect areas of CNVM. Here again, the investigation is a non-invasive technique, so that is importance. Now, fundus autofluorescence. This is useful in inflammatory conditions that involve the retinal pigment epithelium. So here, hypoautofluorescence indicates a loss of photoreceptors or the retinal pigment epithelium. So this is a case of Serpiginous Carotiditis, and the choroidal atrophic areas are seen as hypoautofluorescent area. And if there is exacerbation, it can be seen as a hyperautofluorescence, especially at the borders. You can see there is a hyperautofluorescence. Now, multifocal choroiditis is seen as punctate hypoautofluorescent spots, which is corresponding to the area of multiple chorioretinal atrophies. Now, ultrasound biomicroscopy. The indications are one is UGH syndrome, this is to identify the IOL haptic position. Then this is to assess, to decide on the treatment whether medical management is enough or we have to expand the intraocular lens. Now, pars planitis, you can look for membrane or exudate over the pars plana region. If there is a hypotonia, then you have to look for ciliary body detachment. Then ciliary body tumors can be identified, which can masquerade as uveitis. Now, ICG, the indications are choroidal inflammatory lesions. It can be choriocapillaritis involving the choriocapillaries or involving the stroma, that is a stromal choroiditis. So choriocapillaries like APMPP, nudes, stromal choroiditis examples of VKH, tuberculosis. So in APMPP can be seen as hypofluorescent areas in both early and late phase of the study. So this is because of the non-perfusion in the choriocapillary level. Nudes also, we can see patterns of hypofluorescent spots throughout the posterior pole. And VKH, which is involving the stroma, again we see a hypofluorescent dark dots, and that remain hypofluorescent in the late phase also. Now, FFA is an important investigative modality in uveitis. The indications are one is to confirm the activity of the chorioretinitis, to detect macular edema, CNVM, to confirm VKH, APMPP, and also to assess the response to treatment. To confirm activity, if it is an active lesion, there will be diffuse leakage. This is a case of Serpiginous Carotiditis. Here, the usual pattern is early hypofluorescence followed by late hyperfluorescence. In macular edema, we get a typical petalloid pattern, especially cystoid macular edema. And this petalloid pattern of hyperfluorescence is due to the peculiar anatomy of the parafoveal region. CNVM also can be detected by FFA. VKH, we get pinpoint hyperfluorescent areas. It's also known as the starry sky pattern. Now, in vasculitis, we get areas of non-perfusion, capillary non-perfusion areas, and late leakage from the vessel wall. Macular ischemia also can be detected by FFA. That is also a reason for poor vision. Now, ultraviolet field FFA. This is to detect the peripheral lesions. So, if you do a normal FFA in this case, you will miss these findings. This is also this is especially important in cases of intermediate uveitis and Eales disease. Now, coming to B scan. B scan is especially important in hazy media. If the media is hazy, if there is complicated cataract, then B scan is the investigation of choice. You can look for vitritis and can rule out retinal detachment, especially when you're planning for intravitreal implants or intravitreal injections. You have to rule out retinal detachment. Then intraocular tumors, these can masquerade as uveitis. So that can be detected. You can see for the retinal choroidal thickening, usually in conditions like VKH. Then posterior scleritis can be ruled out because it can mimic as uveitis. So you can look for a T sign. So some retinal abscess can be seen. Now coming to radiological investigations. In chest X-ray, you can look for hilar lymphadenopathy. This is one common investigation in uveitis. So what are we looking for in chest X-ray? Hilar lymphadenopathy, if you're suspecting sarcoidosis, tuberculosis, Then tuberculosis, if there is a strong suspicion, can look for miliary opacities, or lung malignancies can also be detected in X-ray that can masquerade as uveitis. Now, ankylosing spondylitis, if there is recurrent anterior uveitis, then you have to look for sacroiliac joint narrowing and ankylosis of the spine. You can look for a bamboo spine appearance. Then MRI in uveitis, always get the increased uveal tract enhancement. You can also identify masquerade syndromes. And if you're suspecting some multiple sclerosis, you can go for MRI brain also. Now, CT, you can do a HRCT to look for mediastinal lymphadenopathy if you are suspecting sarcoidosis. Sometimes, rarely, if you're suspecting some cysticercosis, you can look for hypodense mass with the central hyperdense cortex. So these are the investigative modalities we have. That's all for today. Thank you.
Thank you, Dr. Rekha, for that very practical presentation. The last speaker of the day is Dr. Pappa, who will be speaking on the complicated scenarios in uveitis. Over to you, Dr. Pappa.
Now we have come to the last part of this instruction course, that is the complications of specific uveitis. I will be dealing with some of the complications. So one of the important type of specific anterior uveitis is Fuchs uveitis, and the common complications are cataract, that is around 70 to 80%, and glaucoma around 13 to 59%. It is characterized by unilateral uveitis, with the glaucoma is mainly because of the open angle type due to trabecular damage. Now about the cataract in uveitis, more than 50% develop cataract, and it has got a polychromatic luster or breadcrumb appearance, usually posterior subcapsular location, and treatment is definitely surgery under steroid cover. We have seen that detail by the previous speaker. Glaucoma, the incidence of glaucoma in uveitis around 20%. It can be angle closure diet because of pupillary block, or it can be due to peripheral anti-vicinity. And open angle glaucoma is mainly because of the inflammatory trabeculitis or due to trabecular scarring, or it can be due to the drugs given as steroids or clogging of trabecular measure. Treatment is medically you can control the IOP, and finally surgery with glaucoma drainage devices. And in Iris Bombay, you can do the laser PA. This is one uveitis with elevated IOP. It is post-Schlossman syndrome, and the feature is that the disc will be normal and the visual fields will be normal. Treatment is with steroids and anti-glaucoma drugs. And uveitis in juvenile rheumatoid arthritis, the commonest complications are band keratopathy, that is around 40%, followed by cataract 30%, and glaucoma 15%. And this band keratopathy can be treated with chelating drugs. Viruses which can affect the anterior uvea include the herpes simplex, varicella zoster, and CMV. The commonest is the herpes simplex. The complications are corneal opacity in 60%, glaucoma, followed by sectoral iris atrophy and cataract. Intermediate uveitis most commonly causes cystomacular edema. It can also result in peripheral capillary non-perfusion and neovascular formation, traction arteries in the periphery, macular changes like ERM. Now for the cystomacular edema in uveitis, 50% of all uveitis patients can develop a cystomacular edema, and most commonly seen in intermediate uveitis, and the most common type is cystoid edema, that is 80%. Other edemas are diffuse edema as well as serous detachment of the macula, and the treatment is with steroids. Other macular changes are because of the inflammatory response, there can be vitreomacular traction and macular hole formation and epiretinal membrane formations. Coming to the posterior segment, the most important complication is the choroidal neovascular membrane. As you can see in this picture, there is a case of ocular histoplasmosis with multiple scars, but in the right eye there is a subfoveal CNVM. So inflammatory CNVM, the mechanism is due to, because of inflammation there is release of VEGF, which results in CNVM formation, or there can be break in the retinal pigment epithelium due to atrophy, which results in proliferation of the new vessels. And the appearance is classic in FFA, it is type 2 in OCT, and the commonest site is subfoveal, commonly seen in POHS, PIC, serpiginous or VKH. And the treatment is with anti-VEGF and shows good response. Even with one injection, the membrane may grow. But if the patient has got active inflammation, you should combine it with systemic steroids and immunosuppressants. PDT has no role because it increases the inflammatory response. Sympathetic ophthalmia, you can see the multiple dialentic nodes with exudative RD, and there can be optic atrophy in the convalescent stage with development of CNVM also. Peripapillary CNVM is commonly seen in sarcoidosis because of the chronic disc edema. In response to treatment, you can see the hemorrhage has gone. It can also result in disc granuloma, which results in defective vision. Serpiginous Carotiditis also, you can see in the right there are multiple heel scars, but when you do the fluorescent angiography, you can see the hyperfluorescence corresponding to CNVM. So incidence is around 35%. Multifocal choroiditis also results in CNVM formation due to any cause. APMPP is a self-resolving condition, usually will not cause much complication, but rarely CNVM can occur. And this is a patient, 14-year-old female, diagnosed as weak age on systemic steroids, but she stopped treatment in between and she developed pain in the left eye. The right eye showed multiple synecdoche with 6-9 vision and normal IOP, but the left eye you can see the iris Bombay and the IOP was around 52. We have done a PA for this patient. Leakage also results in other complications like CNVM, around 10 to 15% as in this patient, or subretinal fibrosis, or chronic cases can result in sunset glow appearance of the fundus because of the diffuse RPE atrophy. This is one young patient, it's a long case of leakage on follow-up, and he developed a defective vision in the right eye, and there was a lesion between the disc and the macula, and the OCT showed a CNVM. Fluorescent angiography confirmed, and we have given anti-VEGF for this patient. Birdshot choroidititis also presents choroidal scars, and the complications are it can result in cystoid macular edema, it can result in vasculitis of major vessels, ERM formation, and choroidal neovascular membrane. Retinal detachment, the incidence is around 3% in uveitis and can occur in toxoplasmosis as in this patient with hazy media, or in case of acute retinal necrosis by the viruses which causes necrotic retina and retinal detachments, or it can occur in CNV retinitis where you can see the multiple hemorrhages and exudation with an associated RD also. Other complications in toxoplasmosis include it can cause a scar in the macular area causing defective vision, or a choroidal neovascular membrane developing near a scar which may respond to anti-VEGF agents. Candida endophthalmitis also results in retinal detachment, CNVM, and the end-stage phthisis bulbae. Tuberculosis, along with the anterior segment complication, it can also result in CNVM formation as in this picture, or it can result in a subretinal abscess formation or a choroidal granuloma, which can also cause defective vision. And serpiginous like uveitis can develop in tuberculosis, and in this patient, the patient has developed a neovascular membrane that you can see in the OCTA. These are some of the occlusive vasculitis seen in uveitis. Behçet's disease prone to occlusion causing a venous occlusion, and in this picture you can see the occluded vessels, and this is a candle wax dripping seen in sarcoidosis, which is prone to vasculitis, and this kind of vasculitis may result in neovascularization of the retina resulting in vitreous hemorrhage, and the patient may need a laser also. Toxocara in children can present as endophthalmitis-like picture or a peripheral granuloma causing macular traction, or a posterior granuloma resulting in amblyopia as well as cataract formation. Hypertonia in uveitis is also a recognized complication. Incidence is 10% seen in chronic uveitis in young patients also. In acute stage, it is due to the cyclitis, and in chronic stage, it is because of the ciliary body atrophy and cyclodialysis. Treatment it with steroids and surgery. It causes defective vision because of hypertonic maculopathy. Phthisis bulbae is the end-stage the disease, and around 25 to 30% of phthisic patients are due to uveitis, and you can get a disorganized, dysfunctioning globe, and you can see the calcification in the CT. And treatment is mainly for cosmetic appearance. You can do an enucleation and put an orbital implant and prosthetics. Thank you for the patient listening.